Our speaker today is internationally renowned for his clinical and research prowess in hematological malignancies. He is a distinguished member of the Myelodysplastic Syndrome NCCN Guideline Committee, which is the main committee that sets all the treatment guidelines for how to treat various oncological malignancies. He's also internationally renowned in MDS as well. I'm, of course, speaking about Dr. Rami Komrokji. Dr. Komrokji serves as the vice chair of the Malignant Hematology Department and the head of the Leukemia and MDS Section at the Moffitt Cancer Center in Tampa, Florida, a premier comprehensive cancer center with international recognition. He is a senior member of the Malignant Hematology and Experimental Therapeutics program at the Moffitt Cancer Center and professor in medicine and oncological sciences at the College of Medicine at the University of South Florida in Tampa, Florida. He earned his medical degree in 1996 from the Jordan University School of Medicine. He completed his internal medicine residency at Case Western University St. Vincent program, followed by fellowship at Strong Memorial Hospital at the University of Rochester in hematology and oncology and hematopoietic stem cell transplantation. Dr. Komrokji is world-renowned international expert in myeloid neoplasms, where he led several clinical trials and lectured worldwide. His work paved the way for the FDA approval of Luspatercept in MDS and pending approval for Pacritinib in myelofibrosis. He has either authored or co-authored more than 275 peer-reviewed manuscripts, 20 book chapters, and more than 700 abstracts in hematological malignancies. He, as I had previously stated, served as a member of the MDS panel of the NCCN Guideline Committee and currently is a member of the NIH MDS Natural History Studies Steering Committee and Aplastic, Anemia, and MDS Foundation Board of Directors. He was a member of the editorial board of the Journal of Clinical Oncology, one of the premier research journals in the whole field of oncology. He's a premier reviewer also for several medical journals, including Blood, JCO, and Leukemia Journal. Dr. Komrokji's research interests are in phase 1 and 2 clinical trials and in the outcome research in hematological malignancies with a focus on myeloid neoplasms. His clinical interests are myelodysplastic syndromes, acute myeloid leukemias, and myeloproliferative neoplasms as well. And so without further ado, it is my honor to welcome Dr. Komrokji. Thank you so much.
Good evening, and thank you very much for the kind introduction. I'm happy to be here and talk about the subject of passion for me, myelodysplastic syndrome. And hopefully, as we will go through today, you will see that we've made progress in treatment and understanding of myelodysplastic syndrome. So really, I wanted to focus on more of the future of MDS treatment or questions that we are trying to answer in the field of myelodysplastic syndromes. So as the audience know, myelodysplastic syndromes are a heterogeneous group of neoplastic stem cell diseases. So those are blood cancers. They are clinically characterized by bone marrow failure with cytopenias and the resultant complications. Nowadays, we can demonstrate evidence of clonality in almost 90% of the patients. And in general, myelodysplastic syndromes are actually probably the most common myeloid malignancies. The average estimates are roughly around 50,000 cases per year in the US. It's a disease of the elderly, so the average age is 70. When we look at all the MDS patients, around 30 to 40% of them will progress to acute myeloid leukemia. However, unfortunately, also 50 or 60% of the patients with MDS will die from complications related to the disease, namely cytopenias, or the interaction or the interplay with other comorbidities. In the past, we used to really struggle because MDS was not considered a cancer by the registries, which we know for sure it is. Nowadays, that's been fixed in a way. And the name is almost a misnomer because dysplasia is a morphologic description of the abnormal looking cells. It's not a precancerous description. And we think that there are obviously cases undiagnosed because anemia is common in elderly, and MDS is actually one of the top 5 causes of anemia in older population. Now we've made some progress. So obviously MDS was recognized years before as a pre-leukemia and then evolved at its own category. I think clinically the important landmarks are shown here. In the 1997, the first classification or prognostic scoring system was proposed. It's referred to as the IPSS, or International Prognostic Scoring System, where you really estimate the risk of the disease, and the goal is to tailor the treatment based on the risk of the disease. Then in the early 2000s, we got first drugs approved for myelodysplastic syndrome, hypomethylating agents, 2 drugs, azacitidine, decitabine, and then lenalidomide, particularly for patients with a certain cytogenetic abnormality called deletion 5q. And then we went into this drought of really no further drug approved till last year or the year before, where we got Luspatercept, which is drug used for treating anemia in a subset of lower risk MDS patients. And the decitabine that we've used for several years became oral medication that can be available for patients. However, in between, we really had revolutionized the way of understanding of the disease because of the advancement in technologies such as the ability to look at gene mutations and understanding the molecular biology of the disease. This year, there was the first proposition for a revised scoring system called International Prognostic System Molecular. And the WHO is working on reclassification of MDS, integrating all this molecular information we learned in the last few years. Now, obviously, MDS is diagnosed by clinical history. Patients will have low blood counts. You exclude nutritional deficiencies, other abnormalities. And finally, patients will get bone marrow aspirate and biopsy. It requires an experienced hematopathologist to demonstrate either increase in the myeloblasts, but below the threshold of leukemia, so 5 to 20% blasts, or what we call the dysplasia, which is the abnormal looking cells, where they count 200 cells of each cell line. And if 10% or more are dysplastic, that's called MDS. And nowadays, sometimes by certain cytogenetic abnormalities, we can call the diagnosis. It's important to emphasize that one should spend time making sure that the accurate diagnosis is made. In our experience and data published from our colleagues in MD Anderson, in around 20 to 30% of the cases, we change the diagnosis, either mostly upstaging the patients, but we've seen, unfortunately, patients labeled as MDS and treated for many years, and they did not have the disease. So it's crucial to spend some time making the diagnosis. Then the next step is really the risk stratification with what I refer to as the IPSS or the IPSSR, because obviously this is important information for the patient prognostically, but you tailor the treatment, and namely thinking who we are going to think for sending to allogeneic stem cell transplant based on the disease risk. So all those risk scores are basically similar in a way that they integrate certain clinical features, the percentage of the myeloblasts, the degree of cytopenia on the bone marrow, and the degree of cytopenia and the cytogenetic information. And you get a lump score, and you divide the patient into 1 out of 5 stages. We refer to them as very low, low, intermediate, high, and very high. You could think of them as stage 1 to 5. And you look here, if somebody is really a very low risk, their average survival is around 9 years. While if somebody is a very high risk, the average survival, unfortunately, for those patients is less than a year. So I always like to bring the comparison that a higher risk MDS is really probably associated with worse outcome than some of the metastatic solid tumors that we think of. So for patients that are in the high and very high risk, and sometimes in the intermediate risk, we start thinking of allogeneic stem cell transplant up front for those patients. Now, as I mentioned, we learned a lot about the mutations in those patients, and the MDS is really an interplay between inflammatory milieu in the bone marrow and somatic mutations that leads to a clone of MDS that is characterized by ineffective hematopoiesis. And as other mistakes happen, we get arrest and differentiation, blast, and progress to acute myeloid leukemia. And we know now, as I mentioned, in 90% of the patients, we can identify a somatic mutation. And we know that some of those mutations are associated with worse outcome. And here is shown just an example of 5 mutations identified earlier by Dr. Behar. This was originally a New England paper and then published again in the context of the newer or revised IPSS, showing that if patients have certain somatic mutations, their outcome is upstage, or their outcome is worse, independent of the clinical features. Now, this is what we think of the natural history of MDS, or the MDS is really a continuum. So we have a pre-MDS conditions that we are actually now starting to study and focus on. So there is what we call CHIP, clonal hematopoiesis of indeterminate potential, or some people refer to it as age-related clonal hematopoiesis. And we have something called CCUS, or clonal cytopenia of unknown significance. Those are pre-MDS cases. Those patients don't have any morphologic abnormalities on the bone marrow. With CHIP, actually, patients don't have any cytopenias. If we sequence 100 people with no known medical, hematological problems, 100 people walking in the street above age of 70, around 20% of them will have a somatic mutation in hematopoiesis, or what we refer to as CHIP. Now, in average, they have only one mutation, and that mutation allele size, or the clone size, is typically 10 to 20%, which means 80% of the hematopoiesis is still normal, 10 to 20% is clonal. Those CHIP patients, you can think of them almost like the MGUS and myeloma, that those patients are at prone of developing MDS, but not only MDS, other hematological malignancies. And interestingly, their number one mortality and morbidity is from accelerated atherosclerosis and coronary artery disease. And our group looked at those patients in context of getting chemotherapy for solid tumors. And if patients had CHIP, the risk of developing therapy-related MDS or AML was 12-fold higher. Another fascinating thing we've learning about this CHIP is sometimes after transplant, we see donor-related CHIP. So CHIP mutations acquired from the donor, and there had been cases of donor cell leukemia or MDS reported based on acquiring those abnormalities. Now, CCUS is having low blood count, but the bone marrow looks normal, and those patients on average have a couple of mutations, and the risk of developing frank MDS is almost 50%. Their outcome is very similar to lower risk MDS. So at one point, that line between CCUS and MDS will go away. Obviously, this is very important because that's probably where we could do in the future prevention and try to intervene to prevent the natural progression. So now we are starting introducing clinical trials in patients with CCUS, and there are efforts also to introduce those in CHIP. And it's really, as I mentioned, in the early disease, it's the interplay between inflammation and those mutations that leads to the disease. Now, once the disease occurs, as we said, we have lower risk MDS, ineffective hematopoiesis, and then we have the higher risk, and then obviously some of those patients will progress to acute myeloid leukemia. So, once we made the diagnosis, we risk stratified the patients based on clinical variables and some of the mutation information. Obviously, we try to put the patients in either a lower risk group or a higher risk group. So in the lower risk group, there are still really open questions. Should we treat those patients earlier? To date, there is no randomized clinical trials demonstrating survival advantage of earlier treatment or any survival advantage in the lower risk patients. But can we really identify lower risk patients with poor outcome that maybe will be able to demonstrate the survival advantage? Should we just wait to treat patients when they are transfusion dependent, or should we think, to start to intervene earlier, preventing transfusion dependency? Because obviously the main challenge in the lower risk MDS that those patients have a bone marrow failure and they become transfusion dependent over time, with all the complications of blood transfusions as well, and the complications of the cytopenia. And obviously we still have way to introduce other novel therapies and agents. As I showed you, we only have probably 3 or 4 drugs FDA approved for this disease. Now, going back a little bit to the risk stratification, this is work by Dr. Nazha when he was at Cleveland Clinic that we were part of, trying really to leverage AI, machine learning, and come with personalized models where we looked at clinical variables and mutations and tried to develop models for better understanding of the disease risk. If you see in figure E, in purple are patients that we thought that clinically will be lower risk, but they really behave, more like a higher risk. And if you look at the line that I draw there, unfortunately, probably somewhere 25 to 50% of what we call a lower risk still die from the disease in the first couple of years of the disease. And we are trying to understand this, what's the pattern of the disease progression? This is work we presented at the past ASH meeting from our group. And we presented something similar also from another database called the MDS Connect. And basically, patients that are labeled lower risk, majority of them, 70 to 80%, will stay as lower risk. Their disease will not go to AML. However, unfortunately, as I mentioned, 50% of them die from complications, namely cytopenias, or the interaction of cytopenia with other comorbidity. For example, if somebody have underlying coronary artery disease, and those patients are, all the time anemic, obviously that could exacerbate the other comorbidities. There is a group of patients that will go to higher risk MDS and stay there. There is a group that will go to higher risk MDS and then AML. And there is a group that progresses from lower risk MDS to AML. And we presented some data that there are certain clinical variables or somatic mutations that can predict those patterns of progression. So really our task in the future is to try to identify that 30% of patients that progress, because maybe we should be treating those patients as a higher risk, and then obviously work on alleviating cytopenias and the causes of morbidity and mortality in the group that stays in the lower risk group. So for example, this is one attempt in terms of early intervention. Lenalidomide is a drug approved by the FDA for patients with a deletion 5q. That's a unique subset of MDS patients, predominantly anemic. They become heavily transfusion dependent. And historically, we treat those patients when they become transfusion dependent. But lenalidomide is probably one of the most active therapies we have, especially for the deletion 5q. So our colleagues in Spain, designed this study rather than waiting till the patients becoming transfusion dependent. They said, how if we intervene earlier and we do treatments earlier, and our goal would be time to transfusion dependency rather than independency. So they did lower doses of the lenalidomide, only 2 years treatment. And what they demonstrated is basically the time to transfusion dependency was almost 6 years with this approach, compared to the standard where patients within 2 to 3 years will become transfusion dependent. A high percentage of those patients achieved a cytogenetic response. So again, this is challenging a little bit our dogma that we should wait till patients are transfusion dependent, but it also depends on identifying active and novel therapies, such as like the high activity of lenalidomide in patients with deletion 5q. Now, MDS with ring sideroblast is a unique subtype. It's not the most common, but it's the most prevalent because those patients have favorable outcome. So in any database of MDS, they probably are around 20% of the patients. By morphology, they have those ring sideroblasts. Sidro in Greek is iron. So they have this, as shown in figure B, a perinuclear iron deposit because of the defect in the mitochondria transporting iron. Ring sideroblasts are not unique to MDS. You can see ring sideroblasts in hereditary sideroblastic anemias. You can see it, after certain medications. And I always say, like in patients where there's no molecular abnormality, the most important is to rule out copper deficiency in those patients. But with doing all that workup, obviously it is a dysplastic feature. Those patients with ring sideroblast MDS subtype have a common molecular phenotype with a splicing mutation called SF3B1, which tends to be the only mutation in MDS associated with favorable outcome. Everything else is neutral or unfavorable, but SF3B1, particularly if isolated, have a very good prognosis. And based on that, there is proposal to now have a entity of MDS called SF3B1 MDS with the criteria shown here, how to identify or classify that category. This was work published by Dr. Marcovati from the Italian group, but it was on behalf of the international working group. We were part of it, and we published later on from our database, validating that showing this subgroup have a very good outcome in terms of survival. However, again, those patients are predominantly anemic, and they become transfusion dependent almost on a weekly or every other week. So Luspatercept is the newer treatment that we got approved, particularly for this subtype. Luspatercept is a fusion trap protein that will bind TGF-beta ligands, family of ligands that it turns out that they regulate terminal erythroid differentiation. So you have your erythropoietin that works on early erythroid progenitors, while the terminal erythroid differentiation is regulated by TGF-beta ligands and other things like GATA2. And if you neutralize those ligands, you will release that terminal erythroid differentiation. So based on activity of this drug, originally we tested similar drug called Luspatercept in our group. Then our colleagues from Germany tested Luspatercept. We observed higher activity in patients with ring sideroblasts. So this phase 3 trial that was published in New England Medalist was designed for patients that are lower risk, have ring sideroblasts that are transfusion dependent. Luspatercept is a subcutaneous injection once every 3 weeks. And the study obviously was positive, showed almost 1/3 of the patients became transfusion independent and led to the approval of the drug. And obviously the maximum benefit of this drug is really in patients that are not heavily transfusion dependent. Those patients that were not getting more than 4 units of blood every 8 weeks, almost 60 or 70% of those patients achieved the response. In general, very tolerated drug, less than 5% discontinuation because of side effects, fatigue, some GI toxicity, and musculoskeletal pains are the most common things. And now this became a standard of care for patients with ring sideroblasts if they are transfusion dependent after ESA failure. Now, obviously, hypomethylating agents are used in the lower risk. I always think that we overuse them, and we try to reserve them as our last line of therapy in the lower risk patients, or if patients have cytopenias like neutropenia or thrombocytopenia, that will dictate the use of hypomethylating agents. And as I mentioned, there are 2 medications, azacitidine and decitabine. So we've been trying to look at, can we get by lower doses? This is work published by Dr. Jabbour through the MDS Consortium. And we finished the phase 3 randomization looking at maybe 3 days regimen of hypomethylating agents could be appropriate in lower risk MDS patients. Immunosuppressive therapy also is another option of treatment we have for the lower risk patients. In general, so underutilized in MDS and with different schools of thoughts on this. So some institutions will use ATG cyclosporin only for patients that have what we call hypoplastic MDS. So the bone marrow is empty, because obviously ATG cyclosporin is the treatment for aplastic anemia, and hypoplastic MDS is very similar, or even sometimes hard to distinguish from aplastic anemia. But by the NIH experience, age is actually the most strong predictor of response and the transfusion duration and burden. And similarly, our group also published the same, that basically age, early introduction in the disease. So in our group, and I think the NIH the same, in patients that are young, below the age of 60 or 65 after ESA failure, if they don't have bad disease risk features, this is the treatment that we prefer as a first line after ESA failure. With, if we select patients, almost 50% responses, tri-lineage responses, and durable responses. In terms of what's on the horizon for the lower risk, the Imetelstat is a drug that is actually finishing phase 3. This is a telomerase inhibitor. In MDS, there is telomere length shortening. So the idea with further inhibition, maybe that will, eliminate the clone. And in phase 2 study, published now by Dr. Steensma in JCO, they showed around 40% transfusion independency, durable, independent of baseline transfusion burden, and in a small subset of patients that had that SF3B1 mutation that I mentioned, 9 out of 11 patients had some reduction in their allele burden with the treatment. So we hope that the phase 3 clinical trial will be positive, and that will lead to our next drug approved in the lower risk MDS. So how do I personalize treating lower risks now? So as I mentioned, we try to go through this risk stratification, spending some time up front, looking at the clinical features, molecular features, using some of the newer models. I mentioned a model that we developed, but as I mentioned this year at ASH, the IPSSM was introduced. So we really try to gauge the exact risk of the disease. Sometimes you follow those patients a little bit to get an understanding of the tempo of the disease, and try to identify those patients that have unfavorable outcome and maybe think of treating those patients as higher risk. On the other extreme, if patients are completely asymptomatic, adequate, blood counts, there is really, no indication to treat those patients. If patients are cytopenic with profound cytopenias, then we ask the question, what is the cytopenia? In most of the cases, we are treating anemia. In occasional cases, we are just treating isolated thrombocytopenia. For some of those patients, we actually use TPO stimulants like eltrombopag, ATG cyclosporin, and hypomethylating agents are the only options. Neutropenia per se in lower risk, I typically don't treat unless patients had recurrent infection. There is no evidence of this chronic use of GCSF or antibiotics that will help. But if patients obviously have recurrent infections, then we treat those patients with limited options currently for isolated neutropenia, only ATG cyclosporin for the younger, hypomethylating agents probably for the older patients. So we really, I usually don't treat, and I have several patients that have, isolated neutropenia for many years without problems. But if there are recurrent infections, obviously that's indication. And then in the majority of the patients, as I mentioned, anemia is the hallmark of the lower risk and the most common indication to treat, because majority of those patients over time will become transfusion dependent. We use erythroid stimulating agents, lenalidomide if they have deletion 5q. Sometimes we use lenalidomide outside deletion 5q if patients have just pure anemia. Luspatercept for patients with ring sideroblasts, but we are exploring its role outside that. Hypomethylating agents as like third line therapy maybe, or in patients that have concomitant thrombocytopenia and neutropenia where you cannot use the other options. ATG cyclosporin for patients that are younger, early in the disease. And hopefully again, we will be expanding our options with the newer drugs for lower risk. All right, so let's move a little bit for the higher risk. So as I showed you earlier, the higher risk disease, unfortunately, those patients have a median survival of less than 2 years. So we immediately start thinking of proceeding to allogeneic stem cell transplant. And for many, many years since the approval of hypomethylating agents, azacitidine or decitabine, that had been our standard of care. So hopefully, the questions now, can we improve that? And can we start thinking of total therapy, taking advantage now of our abilities to start identifying minimal residual disease? And can we really move or improve the outcome in patients with higher risk? So allogeneic stem cell transplant is the only curative option. Roughly around 40% of the patients will be cured. There is always the 20% transplant-related mortality. So it's weighing the benefit and the risk of this procedure. And in higher risk patients, by Markovian decision models, the maximum gain of survival is actually proceeding to transplant. And this is a recent randomized clinical trial based on donor, no donor, showing advantage of the transplant in patients with higher risk MDS. What dictates outcome around transplant usually is the blast percentage, the myeloblast percentage, the cytogenetics, but we learned over time also molecular information is very important. So in patients that have a TP53 somatic mutation, if they go to transplant with a detectable mutation, those patients have probably the worst outcome, with almost 60 to 70% of those patients relapsing within a year. So our group at least we try our best to try to reduce the allele burden or eliminate this mutation before going to transplant, because I find it ethically hard to put somebody through a transplant, an intense procedure with around 70–80% chance of recurrence within a year. There are, and this is some of the work that we've published, small series, not randomized clinical trials, but looking in those patients with P53, the best outcome really, if you clear or reduce this P53 mutation and take patients to transplant. There is a lot of controversy around, the transplant. Obviously, what's the role of treatment before transplant? Practically, most transplant centers would require patients to have myeloblast less than 10%. The role of intensive chemo versus hypomethylating agents versus where we should really bring the disease down to before a transplant, the debulking in a way, is really not established. Some argue that you could take patients immediately to transplant, particularly if the blasts are not increased, and there are no randomized clinical trial. My personal bias that there's probably benefit, particularly now as we get more active therapies, if we get patients into better response, maybe even a minimal residual disease status, then to proceed to transplant. But obviously, again, there are different school of thoughts, and there is controversy with no randomized prospective trials. There is also controversy about the role of post-transplant maintenance, and it's an area of active research to try to see are there patients will benefit from some maintenance therapies after transplant in MDS. Now, the reality is nowadays, the standard of care, as I mentioned, still remains the hypomethylating agents, azacitidine or decitabine. And if you look at all MDS patients, probably only 20% of the patients will get allogeneic stem cell transplant, mainly because obviously of the age of the patients, comorbidities, functional status. Age per se is really not an exclusion for transplant. We do transplant patients up to age of 75 nowadays, but it's really the comorbidities and frailty identifying the donor. So with the best intent, even sometimes probably only 50% of the patients that we are thinking that we are gonna transplant get transplanted. And again, the decision of transplant is very complex, has to be individualized. Obviously, in higher risk disease, the benefit outweighs the risk. In older patients, I learned to sit down, individualize the decision, try to get the patient to understand the margin of benefit or gain in survival, because obviously transplant also is intense, a month in the hospital, 2-month apartment across the hospital, a year of quality of life affected. So we really have to weigh the benefit and risk. But for majority of patients, they get either azacitidine or decitabine in the higher risk. The original clinical trial that led to their approval showed almost 24-month survival, something that we've not been able to replicate in real life. If you look at the SEER data shown here on the left, it's around 11 months. From our MDS consortium, around 17 months, and almost 50% overall responses, and less than 20% of the patients going into complete remission. So that's our current standard of care bar. And definitely, obviously, we need to do better and improve that bar and outcomes for our patients. Now, obviously, the dogma always is to start those treatments immediately in the higher risk. So we challenged that a little bit, and we asked, like, if patients are not going to transplant, if you have a 85-year-old patient diagnosed with higher risk MDS, but no profound cytopenias, they have adequate hemoglobin, they are not transfusion dependent, platelets are above 50, neutrophils are okay, do you really have to treat immediately? Or could you wait till you start seeing progressive cytopenias? And in that group of patients where your intent is not curative, what we were able to show that the outcome were really not different. So if I have patients that we are not going to transplant and they don't have profound cytopenias, I think it's reasonable. Obviously, as we get more active therapies that can achieve minimal residual disease or could alter the natural history of the disease, the optimal timing may be moved again to earlier. But in majority of the higher risk patients, actually, they do have, profound cytopenias, or they are getting ready to transplant. So we end treating, obviously, most of the higher risk patients with hypomethylating agents immediately. Now, the other drug got approved recently is oral decitabine. This is based on a bioequivalence study led by Dr. Garcia Manero, where patients were randomized between oral and IV decitabine. And the bottom line, the oral decitabine was 100% bioequivalent and showed very similar responses to what you'd expect with the IV decitabine. So nowadays, we have the option of providing total oral therapy for the patients in the higher risk. It's important to note that you still have the cytopenias, and close observation for the patients is as needed as we do the IV treatments. And obviously, there is another hypomethylating agent, azacitidine, approved for maintenance in AML, but oral azacitidine is not bioequivalent to IV or subcutaneous azacitidine, so they are not interchangeable, while oral decitabine is very interchangeable with IV decitabine. So we always say, sometimes, mention that the higher risk MDS, there has actually been some, publications or editorial about that, naming it as the boulevard of broken dreams. Because unfortunately, we've tried to conduct many trials adding to the backbone of hypomethylating agents, and they were all, unfortunately, negative studies, not leading to improvement over the hypomethylating agents alone. But hopefully, again, we are at a state now where we have several phase 3 clinical trials, and that we finally will be able to move the bar higher in patients with higher risk MDS. So there are a few drugs that are in phase 3. I'll just mention a few of them. Magrolimab, this is a anti-CD47. CD47 is known as the don't eat me signal. So it's overexpressed in leukemia cells, but it actually, like, overexpressing CD47 prevent macrophages of eliminating or of phagocytosis of the cells. So this is a way for the leukemia or MDS cells to escape phagocytosis. And by blocking the don't eat me signal, you'll allow the macrophages to engulf the MDS and leukemia cells. We finished phase 1, phase 2 studies, and it's ongoing now, phase 3, for hopefully approval of the drug. In the phase 1/2, we saw almost 90% overall response compared to a historical 50% with hypomethylating agents alone, and around 50% of the patients achieving a complete response. So it really looks very promising in the early data. And another thing, it looks agonistic of mutations. So patients that have P53, that I mentioned is one of the worst players that we see in MDS, or worst subtypes, the responses were similar in patients with P53 mutation. The main side effect with the drug is hemolysis on target, because the red blood cells, the mature ones, do express the CD47. But other than that, it's well tolerated. And as I mentioned, it's in phase 3 now. It's moving into the world of AML in combinations with hypomethylating agents and venetoclax, etc. The other drug that's going now into phase 3 and finished randomized phase 2 is a drug called sabatinumab. This is a TIM3 inhibitor. TIM3 are receptors expressed on the T cells, so this engages the T cells, but it's also expressed in the leukemia cells. So there is a dual mechanism action here involving the immune system and targeting the leukemia cells. And in the phase 1/2 studies, the response rates were modestly higher than single hypomethylating agents, but what was notable is that the responses were more durable. So, the combination seems, at least in the early data, to yield into a durable responses. And that's also in patients that have the P53 mutation, where the duration of response reported around 21 months, which typically is, with hypomethylating agents alone, is 4 to 6 months. Even in our clinical trials, it doesn't exceed a year. So this looks promising. And the way we can improve the outcome, obviously, is either we improve the response rates to a very high rate, or we make those responses more durable. So this is also maybe moving in phase 3. Now, venetoclax had become the standard of care for patients with AML. So now patients with AML that are unfit for intensive chemotherapy, they are treated with aza-venetoclax, and we are trying to bring that to the higher risk MDS. This is data on higher risk MDS upfront with the aza-ven combination, and showing very promising activity, overall responses 84%, CRs of 35%. And this is some data that we presented at ASH from real-world experience from our group, comparing a small cohort, 35 patients who received aza-venetoclax for high-risk MDS, compared to a very large historical cohort, showing that the responses are higher with the combination, overcoming some of the mutations like SXL1 that are known to be resistant to hypomethylating agents, and suggesting that the highest benefit with those combinations are maybe for patients going to transplant. So again, a very small subset of patients, they get aza-venetoclax, proceed to transplant. In our experience, the 2-year survival is almost 90% compared to 50% historical. Also, there is interest to bring chemotherapy again to the higher risk. CPX-351 is a drug approved for secondary AML from MDS or therapy related. And now that's also coming back to higher risk MDS, because in the AML data, particularly patients that got this treatment and proceeded to transplant had the most remarkable improvement in their outcomes, where historically less than 10% of patients with secondary AML had a 5-year survival, to somewhere now above the 20%. So we are trying to look at that in patients with higher risk MDS as well. Now, a major challenge and unmet need is basically the hypomethylating agents failure in the higher risk and need for treatment. So obviously, as I mentioned, other than those clinical trials and promising drugs that we discussed, patients can receive hypomethylating agents. Majority are not candidates for transplant. So after HMA failure, we really have no standard of care. The survival is reported somewhere around only 4 to 6 months after hypomethylating agents failure. So definitely this is one of the most unmet need areas in managing MDS patients. Historically, we know that if we were able to take patients to transplant, that's the most favorable outcome after hypomethylating agents failure or clinical trials. Nowadays, taking advantage of some of the molecular information that we have access to, where we resequence patients at time of HMA failure. And you can see here, I've put some examples of targets that if we can identify, we can probably offer patients targeted therapy for those patients. So for example, if you have an IDH mutation, there are IDH inhibitors. FLT3 mutation, there are FLT3 inhibitors, and so forth. So each subtype of those is, if you see, is only 5%. But if you add those up, we probably can, find a treatment that we can offer the patients in almost half of the patients. And one of the interests is also like actually this activity of venetoclax that's noted in patients, after, hypomethylating agents. So this is what we call add back strategy. We continue the hypomethylating agents and add venetoclax, and there had been responses reported, and maybe as a bridge to transplant. And our group also looked into that retrospectively, and we demonstrated that there are response rates seen by just adding venetoclax to azacitidine. And remarkably, in our experience, the group of patients that were treated upfront with hypomethylating agents, then got hypomethylating agents venetoclax for add back strategy, had the longest survival. Posing the question of sequence of those therapies, should we be treating all those patients up front, or kind of think of sequential therapies? Obviously, there is a bias here for patients that receive the ven as add back because they had a duration of response to hypomethylating agents, but just makes us to start thinking, as we have more options, how we are gonna use those, and what is the optimal sequence of those therapies. There are data coming also on those IDH inhibitors, 1 and 2, looking at different cohorts. As I mentioned, they can be used after HMA failure, but down the road, we may use them as single agent. Those are data from our French colleagues at this past ASH, looking at IDH1 and IDH2 inhibitors in MDS patients, again, demonstrating some promising activity. As you know, ivosidenib and enasidenib are approved by the FDA for AML patients. So I think, the future here is, as I mentioned, in lower risk. We need to identify patients with poor risk features, and considering treating those patients at higher risk. We have now a vast opportunity to even identify pre-MDS and maybe alter the natural history. I briefly discussed the CHIP and CCUS, and that's really where we should be focusing on our early intervention preventive strategies. We should start, thinking of different goals in the lower risk as we get more active therapies. In the higher risk, we definitely need to change the bar, thinking of doublets or triplets upfront, incorporate our abilities now to measure minimal residual disease and tailor treatments accordingly. And finally, think of this total therapy approach, where we are gonna have upfront treatment, incorporate transplant, maintenance of transplant, and have like a risk adapted approach where if patients, for example, maybe achieve MRD negativity, maybe we will not need a transplant, and maybe those patients will do well on maintenance. Or it could be the other way, that those patients that if they achieve MRD, similar to data in acute lymphocytic leukemia, they do the best with transplant. But there is no doubt that we have to think of the approach as total approach and start taking advantage of the molecular information that we can obtain now in practice to kind of tailor the treatment accordingly. So I'm sorry, I probably have gone over time a little bit. I tried just to provide overview. I'd obviously like to acknowledge all our patients and their caregivers that without them, would not be able to conduct many of those studies, and our whole MDS team. Thank you very much for listening, and I'm very happy to take any questions or comments.